Just let me know when we're live.
Yes, we're live now, Chair, thanks.
Okay, thank you. Welcome to this virtual meeting of the Health Scrutiny Panel. Can I remind all participants that normal rules of procedure apply? For example, comments and questions need to be directed through the chair. As we're meeting virtually, proceedings may take slightly longer, so your patience is appreciated. As per our virtual meeting procedures, if questions have been received prior to the meeting, I will call on the relevant member at the appropriate time to raise that question. If you are invited to speak, please state your name and be as specific as possible about which issue you are speaking to. Whilst members of the public can view this meeting via YouTube Live, they cannot be able to actively participate or comment on proceedings. This meeting is being live streamed. Can I remind all participants that conduct should reflect this. Thank you. Welcome to this meeting. First of all, do we have any apologies for absence?
Yes, Chair. We have apologies from Councillor McTighe and Councillor Matt Story.
Thank you. Note those. Any declarations of interest? Nope. Right. Minutes of the Health Scrutiny Panel held on the 24th of July have been all distributed. Is there any comments? Are we happy with those? If so, can we agree that they're a true record?
Agreed, Chair.
Thank you. Okay. On to item 4, COVID update. We've got Mark Adams here from the Public Health South Tees and Craig Blair. So, Mark, can I put it over to you? You can give us an update.
Thank you, Chair. Yeah, Caroline, could you share the presentation, please? You're muted. You've unmuted and then muted yourself, Caroline. Sorry. And again. There we are.
Too quick. Sorry, Mark. Yeah, Sue, would you be able to share it for us? I've passed it over to Sue, if that's okay, just so I don't lose sight of everybody on the screen.
Okay, just bear with me a minute.
Thank you.
Okay, so I've just put, well, our data analyst Ali Stewart has pulled together these figures, which are the latest figures up to the 22nd of September, which is today. Not all of the tables are necessarily the same time period, but it is detailed where they're slightly different time periods. So when we get that up, I'll be able to talk through the current picture in terms of cases, which is what we're seeing is largely household transmission. There's no great single source or small number of sources of transmission, such as a factory or a pub or anything like that. It's spread throughout the town, as you'll see on the final slide here. So if you can go to the first slide, please, Sue. Oh. That's not the same as the first slide that I've got. It's just I can just see a black screen. I don't know if that's what everybody else can see.
Yeah, that's what I can see at the moment, Mark, but hopefully it'll come up in just a moment. I don't know whether. Sue, can you advise?
Oh.
Sorry about this. I just lost everything. I couldn't see anything on my screen at all. Was that the correct presentation, Mark, or not?
Yeah, the front slide was right. Yeah, and then it just went to a black screen.
Sorry about that. Let me try again. Sorry about that.
Okay, if it doesn't work, I'll try and share my screen and see whether or not we can do it that way. It's starting to share now. Okay.
Are we there? Sorry about that.
That's okay. So if you want to go to the next slide, please. So this is the cases by week right from the start of the outbreak. So the first little bar is the 16th of March, moving along to week beginning 14th of September. And you can see the original peak that we had through back end of March, April and early May. And then the sort of drop off and then the pick up again from the beginning of August through to where we are now. I think the main thing to say in terms of those cases is obviously the early cases in March, April and May were pretty much exclusively tested in hospital. So they were ill people that were in hospital who tested positive for COVID. The numbers that we've got to the right hand side of the chart is, because we've got test and trace up and running now, is basically people within the community with COVID in the main, although we are starting to see people within hospital with COVID now, and spreading from as we'll see when we come on to it, a younger age group to an older age group. If you could move to the next slide, please. So this is just looking at where we, how we compare to others in the Northeast, and members will be aware that the Northeast 7, because the Northeast splits into the 7 from Durham northwards, and then the 5 authorities within Tees Valley. And what this shows is the local authority on the left. I've just got a grey square in front of that now. There we are. Thank you. And then the current 7-day period, so that's the number of people testing positive there, so 219 for South Tyneside in that first row, and then the rate per 100,000 that people will have seen being quoted nationally, and then the same details but for the previous 7-day period, and then the sort of reddy pink column, the percentage rate change. So if you look at Middlesbrough, it's ranked in terms of by numbers of tests. But if you can see from that, Middlesbrough are near the sort of middle to the bottom of that table with, at this time, up until the 19th of September, 42.6 positive cases per 100,000 population. We're just over 50 now with the updated figures from today, but at that point we're 42, compared to South Tyneside at 145 and Gateshead upwards. Those 4 authorities are all above 100, which is the reason why they took the action that they did. That's since been largely followed by the national action for the they're not calling it a lockdown, but for the measures that they've introduced last night and more detail on today. So that shows where we are, and you can see the increase in Middlesbrough from last week to this week is 9.1%. different to the rate of increase in those other areas. Now, whether or not we catch them up or whether or not we're able to maintain our figures as they are will, to an extent, be a mixture of luck and the action that we're taking. So next slide, please. So this is looking at the cases per day based on the specimen date, so the date that people have been tested, and the orange line is the rolling 3-day average to get a sense of what's the trend that's happening with this. And what we think is that the big increase that we saw on the 17th of September, which is the 19 cases that you see there, is probably as a result of what prior to it happening, we were concerned about the last hurrah being the weekend before the rule of 6 came in at the beginning of that week, and more mix. I mean, this is hypothesis, we can't prove this, but that at the weekend before there was more mixing, and as a consequence more people have ended up testing positive for COVID 3-4 days after the weekend. It works with the timing, whether or not that's true or not. One thing that we've found with the people that we've spoken to, because what we're doing locally is we're contacting all of the cases. So we're not doing contact tracing, we're doing case tracing, if you like. We're contacting all of the cases to get an understanding of where they've been in the pre-symptomatic but infectious period, so that we can work with either settings to understand what action we might need to take. And most of the settings, if not all of the settings we've worked with, have actually had very good COVID secure measures in place. So it's just helped build our intelligence. And I think for most of the people, particularly the younger group that we've spoken to, most of them have been, as our people contacted them say, have been out and about, is the way that they would typify that. So hopefully the national measures in terms of reducing that kind of social contact will have an impact. And what we know about our transmission from the people that have tested positive is around about 80% of our transmission is within households. So it's either people visiting a household or one person in the household becoming positive and then infecting the rest of the people in the household. So that's our main source of transmission, which is exactly the same as you're seeing in Bolton and Blackburn and Bradford and various other places. It's a pretty typical picture, really. Just to comment on the sort of tail at the right hand side of the orange trend, that's not really because the trend's dropping off. It's because there's obviously a bit of a lag. The closer you get to today, there'll be figures that will come in for the 20th and 21st that will increase, that will move that line up a little bit. So we're really looking up until the 19th, which is the peak of that, and hoping that when the cases come in, it doesn't continue on that upwards trajectory, but starts to level out. Next slide, please. So one thing that we were concerned about was testing, because we know, and I'm sure councillors will have had lots of their constituents saying that they've had difficulty to accessing tests. So we were concerned that our numbers that are lower than obviously other authorities in the north, is that driven because they are genuinely lower, or is it driven because we're testing less people? So this is positive tests per 100,000, which is similar, although not the same, because it's data up to the 18th of September as the previous table, but we're 44th highest in terms of the rate of positive tests, however 34th highest nationally in terms of the numbers of tests that we're doing. So the tests at 1,641 per 100,000 compares very favourably with all of the other areas, perhaps with the exception of Hartlepool and County Durham in terms of the numbers that we're testing. And one thing that you would expect to see if perhaps you weren't testing enough people was the percent positive would start to increase. And we've seen it above 5% before, just above 5%. And in this analysis, it's around about 2%. So anywhere below 5% is kind of gives us a little bit more comfort that we're testing sufficient people, and our rates aren't necessarily driven by lack of access to testing, although of course we do know that it is an issue for people, particularly around education and the potential increase in time away from the classroom it adds if people can't get tested. Next slide, please. So this is just to, in terms of the ethnicity, it's a little bit confusing because basically the two blocks on there, the left-hand block is all cases, and the right-hand block is takes out those where ethnicity is. What we saw in the beginning of August was that our outbreak was quite a large extended Asian family, and pretty much exclusively within that kind of Asian community. Although we did say at the time that it was driven by behaviour rather than ethnicity. The concern about ethnicity is that the outcomes are often worse for people from BME background, as people will be aware. But what we've seen now is that shift as you move to the right-hand side of that, things where the majority of cases, 80% of cases, are white British. So there's kind of indigenous population, if you want to think of it like that, rather than an Asian population. I think there's a little bit of a story that sort of suits some people's narrative that it's driven through BME communities. That's just not the case. It's driven through all communities, and it's based upon behaviour. It's not based on ethnicity. The issue with ethnicity is that people from that background are more at risk of having a poor outcome for their health, rather than they're more likely to get it or more likely to transmit it to somebody else. Next slide, please. So this just shows the difference in the age group that I mentioned. So the blue bar is the all, so that's all cases, obviously driven by the March, April, May outbreak, and you can see that the bulk of those cases, almost 20%, are over 80, and that reflects that basically most people that were tested were in hospital, therefore very ill, or in a care home, very ill. And what we've seen is the sort of 20 to 40-year-old population. That's really where it started, exclusively when it started to pick up again at the beginning to mid of August. But what we're seeing is it's starting to kind of leach into the older population now, and so we've got a number of 70-year-olds, a number of 80-year-olds, not in care homes but in their own homes, that have been that have tested positive for COVID. And we're also seeing that reflected more in terms of the activity in James Cook. We don't have activity split down by local authority, but Richard Bellamy, who's the Director of Infection Control for the Trust, said that previously they were getting 2 or 3 COVID cases a week. Now it's 2 or 3 a day, and there's a number of outbreaks on about 3 or 4 different wards within James Cook. So we're starting to see it pick up again. This really is the thing that we were concerned about, the kind of community transmission amongst people who perhaps aren't that ill, but then spreading into the more vulnerable population that get ill or become ill, and obviously worst case die, as we saw in March, April and May. So we're seeing that shift from that younger age group out and about in town and socialising, and now spreading potentially through family members to the older, more vulnerable population. Next slide, please. And then this is the final slide. Just it's a little bit difficult to see, but it just shows you that so the red dots are the cases in the previous 7 days, and the shaded areas are how many cases per local super output area. So it's not quite a ward. It's a smaller geographic configuration. So you can see from the red dots that it's spread everywhere. It's not particularly clustered. That little to the bottom right hand corner of Ladgate, if you go back 14 and 21 days, becomes a little bit of a cluster, which is around the Apple Tree pub. But other than that, we're not really seeing any particular clustering. There's not huge numbers of cases in care homes yet, so we're not seeing that clustering around care homes either. And really, this just demonstrates that in the last 7 days, and it's reflected in the last 14, the last 21 days, basically it's spread throughout the borough. We're not seeing it particularly affecting or clustering in any particular area. It's spread throughout the borough, and as of these details to the 19th of September, there were 66 cases that tested positive in that week. Of the last 7 days, I think it was 72 were tested positive, which is a rate of just over 50 positive cases per 100,000. So that's where we are. Shall I pause there and happy to take any questions?
Yes, thanks, Mark. Just one quick question there. Just going by those figures, looking at it every day that the Gazette does publish the figures, it seemed to go up and up and up, then come down and down, then going back up again. Is that a statistical reason for that, or is that actually true figures?
Well, the very first slide that we saw, so it peaked in sort of mid-April time and came down again, and then started to diminish. We never got to the situation when we had no cases a week, but then it picked up again beginning to mid-August, and now it's picking up in the way that we've seen in that first graph that we saw. I guess the point that I made. In the first outbreak, we had limited testing, no community testing. It was all hospital-based testing. So the numbers, the group of people that we're talking about that tested positive aren't the same. There's very ill people in hospital in the first peak, and then a kind of whole community within the second peak, because we've got a lot more testing available than we had previously. So
I think what you're trying, just before I bring Denise in, just before you're trying to say is that, in fact, the two different graphs, because the graph you show on the left-hand side is purely hospital. On the graph you show on the right-hand side is virtually purely in the community. So actually it's two different things you're comparing, in effect. It's still the same outcome. They've all got COVID, but it's two different groups, and that's maybe slightly concerning because the hospital one hasn't started to peak yet, and let's hope it doesn't.
Yeah, the right-hand one includes hospital as well, but it's about a third hospital to two-thirds community in terms of numbers tested. Yeah, sorry, Councillor Rooney.
Yeah, thanks, Chair. It's basically on the same point. It was something I picked up from your presentation. So the earlier testing, where it was predominantly around the hospitals, was there a suggestion there that it could have been more prevalent in the community, and we just didn't pick it up? And my second just very brief query is, I think on that last slide you showed us, there was no cases in North Ormsby, which I find interesting. So just those 2 points, thanks.
I guess the last slide, it is what it is. If in the last 7 days there weren't cases in North Ormsby, then that's the case, and that's not to say that there weren't any in the previous 14 or the previous 21 days. And your point about if we had the same testing in March, April, May that we've got now, obviously the numbers would be significantly higher, because you'd have a whole lot of people in the community potentially with COVID, as well as those admitted to hospital. But we don't know that because we didn't have the testing.
Yeah, thank you. Any other comments? I have one other comment. Having been in the town last week, and I walked into one of our big shopping centres, and I would say 40% of the people didn't have masks on. I know it's going to be made compulsory, but how on earth can we enforce that? Because people being asked, well, I've got masks. Oh, we haven't got any. Middlesbrough have done a fantastic job, probably the best in the country, for distributing masks, but it's just the enforcement of this just concerns me.
Yeah, and I think right from the start we said this was about a kind of social movement as much as it was anything else, that we could only really do this with the support of the people. So you'll have seen the press about COVID marshals, and we're going to look to use the street wardens to do that as kind of sensitively and delicately as possible. So it's not about going around beating people up that haven't got a mask on, but it's about working with people to
it's education rather than
exactly.
that. Yeah.
Yeah, so the temperature guns that we've had, we know there's no clinical benefit necessarily of a temperature gun, but we've had over 13,500 conversations initiated by having the kind of theatre of a temperature gun and a free mask available. So they've been conversations with people about what you can do to keep yourself, your family and your neighbours safe, which include wearing masks. So it's a long-term thing, this is, I think, in terms of what we have to do as a community to keep each other safe.
Yeah, I was pleased to see that it's going to all shop workers and people working in bars are now going to be, well, it's going to be compulsory to wear. And I think that's a lot of the problem. It not only protects them, which is absolutely vitally important, but it also tells the customer coming in, we've got masks on, you should as well. And I think that's been one of the difficulties personally. Councillor Rooney?
Thanks again. Just going back over the note I was making, you were talking about case tracing earlier on, Mark. Are any other authorities doing something similar? And is there any kind of comparison data coming out, or are we just ahead of the game with this? Because it seems to me like a very forward-thinking thing to do, and in terms of gathering data and information.
I think some of the other authorities further north, so Gateshead, South Tyneside, and Durham, I think, are doing an element of that. We started doing it when we had the first outbreak, so we were the first one in the north east to have the outbreak that we had at the beginning of August, and we started doing it then because it helped us piece together. And we had Idris Rashid, who's our BME network coordinator, who actually knew most of the families that were involved in it and got messages out through the mosques and various other places that were tailored for that audience, so that they resonated with them. And we felt that it was really important to our understanding of what was happening. So we've been doing it since August, and every day we've attempted to trace all of the positive cases that we've had, and obviously we're not successful in all cases, but it helps us build up a picture and build up. We have Andrew Glover from Comms is on our outbreak control team, which we've got 3 times a week. So we're tailoring comms messages as and when we find things. So one of the issues that we've found is that quite often people will go to a thing where the thing itself is quite safe. So whether that's an organised football match or something in a COVID secure venue, but they're getting to and from, or what happens after they've been to that place is where the risk happens. So whether it's sharing a car into a workplace or sharing a car to watch your kids play football or whatever it happens to be, that's the risky bit. The actual, well, as long as the crowd's distanced, that's not particularly risky. And we've been able to get comms out on a rolling basis with a consistent message, but also specific messages along things that we're picking up. So some of the stuff we're seeing within schools around staff transmission and working with schools about how can they prevent, if they've got a staff member who tests positive, determining that other staff member in the school are contacts, the school can take action to minimise that by ensuring social distancing and all the other measures that we've talked about. So I think we feel that we're on top of and understand as much as we can what's happening in our community, because it's a whole load of different household clusters. It's not single entity. But I think the fact that we've done as much work as we can to know that we understand it as much as we can is helpful in itself.
Coming from that, if you have an area where you've got a lot of interaction, and if you've got no COVID cases, then interaction just goes on. If you get a high area where you're starting to get it in, that could be a problem, couldn't it?
Yeah, if we started to see a geographical cluster in a particular place, and we've done targeted comms before, as you'll be aware, in terms of leaflet drops to specific communities and the like, and that's what we would do. Would be, we've also got through the test and trace grants for VCS organisations, voluntary community sector organisations, to tailor messages to specific groups. So whether that be, it's not called Help the Aged anymore, Age UK, for targeting older people, or some of the BME VCS organisations or other vulnerable groups, we can tailor messages through trusted voices in the community, and importantly get messages back in terms of the problems that people have keeping themselves safe, whether that's access to masks or difficulty in distancing or the nature of the job that they're doing or whatever it happens to be. And that's just starting within, that'll be starting next week. And also recruiting COVID champions in communities, so people that have actually got clear messages in terms of action people need to take to keep them safe, and hopefully start to challenge some of the sort of false stories that are around, like it's only prevalent within the BME community and all that sort of thing. We can actually have trusted voices in the community articulating kind of the reality of what's happening and helping us to keep everybody as safe as we possibly can.
Yeah, I think that's very important, I think. Councillor Story, I've lost your picture. If you do need to ask a question, if you can just send a chat message. No, thanks, Mark. If any other questions, I don't see any. Oh, yes, sorry, Councillor Hubbard. Sorry, I didn't see you there.
Thanks, Chair. Mark, given your presentation, one of the slides was about the North East region, and Middlesbrough was quite low, which was, you know, really good. But given the fact that Middlesbrough suffers a lot from ill health, where do we sit in with how dangerous this could be if there is a spike in Middlesbrough?
Well, I think what we saw from the previous outbreak in March, April, May was Middlesbrough had one of the highest death rates in the country. I think we were about 4th in the country, something like that. So we know that you know, a 70-year-old in Middlesbrough is likely to be more poorly than a 70-year-old in Surrey, say. So we've that will be an impact, which is all the more reason why we want to keep people as safe as we possibly can. And you see the same thing further north in terms of Sunderland and Newcastle and places like that, where you've got that sort of post-industrial economy and communities. So I think we're we're definitely in a better position than we were in March, April. So care homes are much safer than they were now, and there's testing before people go into discharged into care homes, either from the community or from hospital, and so on and so on. But to answer your question, yes, if it gets as prevalent as it was and people get ill, the outcomes will be poorer for people in this community than would be in a more wealthy community.
Thanks for that. Thanks, Chair.
I have got a message from Councillor Story. She's asking, could we as councillors have regular updates on testing availability, Mark?
Yeah, we can pull together whatever updates people want, really. We tend to get a little bit swamped with information, and we're sort of trying to pick through what's useful for people as much as anything else. But we can, I mean, the regional testing site at the old, well, it never was Sainsbury's, but there was the Sainsbury's site, is still there and will be there till mid-October. And then I think it's going to move to Cannon Park, because the Sainsbury's site is going to be used for something else. I don't know what else it's used for, but we have mobile testing units which tend to be on a week-by-week basis, but is based at Newport Community Hub, as it has been for the previous few weeks. And we do get testing rates through that, so we can share both locations of where testing availability is. We're also pursuing what's called hyperlocal testing on the university site, but open to the local community as well, to try to increase availability of testing. But it's not clear at the moment what the kind of status of that'll be, given the overall issue, you know, the national issues with testing, whether that will come off or not. But we are pursuing that as well. But if there's information that councillors feel they're not getting, if we've got it and we can sort of package it up in a reasonably easy to pull together and easy to understand way, then we'll do that.
Yeah, I think it is important, because if you get asked by your residents and things saying, where can I get tested? We've got symptoms in the family. You need to be able to find that out. And if you're going to Cannon Park sort of on a more regular basis, that's sort of a little bit more into the centre of the town, perhaps you'll get more and more people tested, which is important. I mean, do you see the availability increasing over the next few weeks? I know there's government targets, but targets are targets. Do you actually see that actually happening?
I wouldn't really like to comment, to be honest. It's a bit of the whole testing thing is a bit of a black box, really. We haven't been briefed on why testing availability suddenly became difficult, other than what I've read in the press around lab capacity and things like that. So we don't really have any details to inform that sort of an answer to that question. I would hope that testing. The testing problems get fixed and we get more testing, because that's really the only way to return some sort of normality, is being able to test people that develop symptoms. And of course, as Janet will know that as we move into cold and flu season, more and more people will have persistent coughs and temperatures. So we'll need to test people quickly and get the turnaround of the results very quickly as well. So it's been very frustrating, and it is a little bit opaque in terms of understanding what's actually happening, which is a bit difficult. But we're making all the representations we can in terms of ensuring we've got as much local testing as possible. Yes,
because that's how South Korea and China, etc., they just test, and that's one of the ways to get rid of it. Thank you. I don't see any other hands up. Do you want to carry on, Mark?
That was the end of it. That was the. I didn't have a big finish. That was the end of it.
I just thought there must have been something special you were going to do. Tell us that it's all going to end in a week on Tuesday. Well, thanks for that, Mark. Thank you very much for those. You've given us some really good information there. I think we all do appreciate that. You've got it pretty well up to date. I'm just concerned this week that we're seeing an upward trend, but hopefully the things that the government are going to put in and local council put in, I think we should be grateful to you and the council for all the work that's been put in. If anybody's doing enough, we are. Thank you.
Thank you, Mark.
Yeah.
Chair,
right.
Sorry.
I appreciate that. I'll feed that back to the team. Thank you.
Yep.
Sorry.
Yep.
Yeah, we've got Janet Walker and Tracy Innes here in place of Craig Blair to give an update from the CCG's perspective in terms of the virtual ward. I think hopefully Dr. Walker is going to be able to share her content, her presentation.
Okay, thank you.
Everybody should be able to see it now, hopefully.
Over to you. Thank you.
Thank you very much, David. Thank you, Caroline. My name's Janet Walker. I'm a GP locally in Aston in Middlesbrough, and I'm Medical Director of Tees Valley CCG. And I was asked to come along today as Craig's otherwise occupied to talk to you about the virtual ward. As we've already talked about obviously COVID-19 is a disease that can affect some people very severely and can make people exceptionally unwell compared to some others who do exceptionally well with it and have a really mild form of the illness. And as GPs, obviously, we always want to try to make sure that we can do the best for our patients in the community. And when we were in the unenviable position of having many more cases in Middlesbrough than elsewhere in the country, and our death rate, sadly, as Mark's already said, were exceptionally high, fourth highest, it did give us cause to think, okay, what could we do differently that would give our population, better outcomes as and when they caught COVID? So we were very pleased to be able to, now, beg your pardon, I'm having trouble driving my slides. Bear with me when I can work out how to get them to go down. I will get it to move down for you. There we go. Okay. We knew we wanted to be able to take action to intervene earlier with patients before they became as sick as they were. We knew in Middlesbrough patients were presenting late in the course of the illness, and when they were presenting late, unfortunately their outcome was much poorer. We knew that some patients had what we call silent hypoxia, which meant that their oxygen level circulating in their blood was really low, but the patients didn't realise how unwell they actually were. Usually with a respiratory illness, people are very aware when they get very short of breath with it and really feel very, very challenged with it. But with COVID, it's a bit different, and they can have this silent hypoxia issue that's hard to identify with using conventional medicine. So we looked at what we could do differently. So we were very pleased that in the Tees Valley, we were chosen to be one of 3 NHS England sites to pilot a different approach to monitor our patients at home once we knew that they were COVID positive or they had symptoms that we felt could be COVID. If we could monitor them in their own home setting in the community to try and pick up those changes earlier, that allows us to intervene earlier, we could potentially improve the outcome for those patients. So we've set up a COVID virtual ward, which, yes, is the national terminology, but that's very confusing to people. So we prefer to call it COVID care at home, which seems to be a much more acceptable version of describing it. Now, the NHS England are evaluating this across the pilot sites with regard to a national rollout. Obviously, it's very early days with our pilot because our pilot began right at the end of July. And as Mark's identified in the figures over the summer months were much lower, but we have obviously now had these outbreaks in Middlesbrough and Redcar, and rates have been increasing nationally as well. So work is ongoing to develop it, but our plan was to work together across the Tees Valley. The 3 GP federations were very keen to work together to provide this enhanced community support. It's a clinician supervised, nurse-led monitoring approach. Anyone who meets the referral criteria, which I'll come on to in a minute, receives a bit of kit. It's a pulse oximeter. It's a simple piece of plastic machinery that goes on the end of your finger and doesn't involve any blood taking or any masks or anything. It just sits on the end of your finger and can pick up what the oxygen level is in your blood. And it's a really accurate, simple, easy to use piece of kit. And with that data that pulse oximeter records, they can submit it via a digital app, and that'll monitor them for a period of up to about 14 days on the ward. And that's a period that we know patients tend to deteriorate within. And so it's a sensible time frame. And the app has an inbuilt safety mechanism so that if the patient does deteriorate, then it automatically triggers some messages that the patient can read on their app that tells them when they need to call 999 for support, or indeed contact the monitoring service. Simple principle, and yes, seem to make good sense, and we hope it's going to prove through the evaluation that actually that can enable us to pick up deterioration and detect changes in people's symptoms earlier. There are different places that the patients can be referred into this service from. We can accept referrals from the GP hot clinics or the primary care access clinics, where a patient who has suspected COVID symptoms goes if they are feeling unwell and are assessed. Referrals can be accepted from the emergency departments across all 3 trusts across the Tees Valley area, and anyone who's in the urgent treatment centres, or indeed anyone who presents to their ambulatory care short stay admission units. They can be picked up and referred on discharge from hospital. They can be picked up by paramedic assessment, and indeed, as Mark's identified, we are now getting a link between the positive patients testing via test and trace. They can self-refer themselves into the COVID virtual ward, as can residents from care homes. The referral criteria is currently very broad. All you have to be is an adult living in the Tees Valley who has a positive test for COVID and has symptoms, or has suspected COVID-19 based on their symptoms that they present with and are suitable for home monitoring. There were a couple of exclusions, which is just patients who are obviously children and patients who have a low level oxygen normally as a result of a pre-existing respiratory condition, or indeed patients who have an emergency healthcare plan in place for whom that you wouldn't want to be intervening, offering a hospital admission as and when they deteriorate. You would choose to manage them differently by caring for them at home. We know that currently the referral criteria are exceptionally broad. When the numbers were very low over the summer months after the start of the pilot at the end of July, we had very low patient numbers on the ward. However, as Mark has identified with the figures he's already presented, the figures are now rising. And currently, as of today, we currently have 24 patients at this moment being monitored on the ward. There have been various challenges. I do beg your pardon. I hope that's the right slide for you. There have been various challenges. We know that it's been quite complex to encourage patients to present to the ward from positive test and trace. There's been some resistance and reluctance, I think, concern about Big Brother watching you and further monitoring rather than support we're offering. But we've changed our terminology to try and describe the service with the right words to make it more accessible to patients. All the patient leaflets are translated into the top 9 languages that are spoken across the Tees Valley. And we've developed easy read leaflets. There has been difficulties accessing the test and trace data. We would all hope that the minute a patient tests positive, that quickly gets into GP practices or quickly gets into the virtual ward. Well, for a whole host of data sharing reasons, that isn't quite the case, although things are improving. And we hope very shortly to allow data from the positive tests to go straight from Public Health England straight into the virtual ward, and then they will be able to proactively contact the patients to offer the monitoring service to the patients, and that hopefully will be happening shortly. As you can see, things have changed significantly since the slide was prepared, because as of the 17th, we'd only had 29 patients. That was in total from July. We now have 24 on the ward as we speak. So obviously things are picking up, but we've had media interest of late. And also we have, in the latest outbreaks in Middlesbrough and Redcar, we have had a link to the offer of the virtual ward or the COVID care at home incorporated into the test and test and trace leaflets that have been circulated when people have been attending for tests. Thought you'd want to know a bit of a patient story about how patients actually feel when they're on the ward. This happens to be a lady from Redcar who was identified by test and trace. She after attending a local restaurant, she became unwell and attended for a test and was herself identified as positive. She goes on to describe that, yes, she felt that she was well supported through the process, that the use of a digital app was easy for her. She obtained good reassurance from that. And obviously, this is an individual who is not in the age group that we would expect potentially to be most poorly. And it's just something we're very keen when we were launching our pilot that we could monitor patients that we thought probably wouldn't need to be monitored, so that we could gather evidence for any national rollout to show, importantly, who didn't need to be monitored as much as those that do. But obviously, it's a useful patient story. We have had patients on the ward in the last 7 to 10 days that have deteriorated and actually currently are in hospital. But we hope our evidence of our evaluation will show that we were able to intervene earlier, and hopefully their outcomes will be better as a result. Obviously, I know we're jumping the gun slightly because we haven't had the outcome of our initial pilot evaluation yet, but from the information we've received so far, patients do indeed get good reassurance and support from the approach. We know that we have been able to identify patients that have deteriorated and hope that, yes, that we have been able to improve their outcomes as a result. I have said that we use a digital app for us to record the patients' readings. That does not mean we exclude patients who don't have access to the ability or within their friends and family to use digital technology, because if a patient hasn't got access to a mobile phone or a laptop to be able to use the app, that the remote monitoring service will enter onto an app via telephone on their behalf. We are hoping that, yes, this will be an important strand for us to manage better as numbers do increase, to make sure that patients stay managed safely in the community rather than needing to trip over into other elements of the NHS. Yes, time will tell. It is true. We will need to flex very carefully the staffing of the virtual ward to make sure we have the capacity to manage numbers as they rise. We are all hoping, absolutely, that the numbers don't rise such that we don't have the capacity to manage, because it's so important that we do want to keep people as well as we can in their community at home. One thing we have identified is those patients who haven't been unwell and haven't deteriorated have been able to manage safely and self-care at home, which is obviously an important part of the process. I've rattled through that because conscious of time, Caroline, but very happy to take any questions or pick up any additional points.
I have perhaps the first question. With this virtual, is it the same for discharging? When thinking about that, you say, well, someone, yes, they're fine or whatever, will discharge them. Is there any monitoring done after that? Because you can discharge someone, say thank you very much, but what happens if their situation gets worse? How do you monitor that?
Yeah, thank you, Dave. Very good question, David. The monitoring that we would expect to do on the virtual ward is for a 14-day period. Now, it is in the evidence so far that we've learned about COVID is that if you're going to deteriorate with it, you tend to do it between day 5 and day 7, or potentially day 10 and day 11. So by the time, if you've managed to get up to day 14, the chances of you deteriorating as part of your COVID illness is unlikely. So that's why the period of 14-day monitoring has been chosen. However, when you are discharged from the ward, you return to the complete care of your ordinary general practitioner, who will have been monitoring and looking after you from anything other than COVID-related symptoms even during the time that you're on the ward anyway. It is true, we are aware that some patients are having a longer course of illness, and there are some respiratory complications that carry on even after that initial assessment period. Under the terms of the admission to the ward, if a patient remains unwell at day 14, what happens is we determine, is it due to COVID that is making them unwell, and do we need to take further action from that perspective? Or are they actually unwell that's actually a condition that's unrelated to COVID? I mean, it's very important that we all remember, whilst COVID is a hot topic, everything else, all the other diseases that have always existed are still there. And so we do need to make sure that we don't forget about all these other conditions.
And of course, you do the same in the care home as well. If they're actually in the care home, they're still there. They're in the virtual ward, and you'll make sure that the staff in the care home are trained up as appropriate to spot the signs and make sure they can get back into the system.
Yeah, no, absolutely. This is an enhanced chunk of monitoring that covers that 14-day period. The patients will still continue to receive all the usual care that they would receive from their general practitioner as well, though.
Okay. Councillor Halawi, yes.
Thank you. Thank you, Chair. It's just about a notional idea in terms of numbers. So how widespread sort of geographically is the virtual ward, or how many people could it cope for ultimately? I mean, I suppose that's dependent on how many staff can be recruited to look after people. So I just wondered, you know, how you could cope if there was a big surge, and to what extent you could cope before you would be overwhelmed or...
Yeah, no, yeah, absolutely, Emma, and Councillor Halawi, and I take on board the question. We know that at the moment in this very early pilot evaluation stage, our referral criteria are exceptionally broad for us to gather that data. Now, we know that obviously numbers lately on the ward have increased, and in answer to your question, how many patients can we cope with? At the moment, there is plenty of capacity within the service to manage the patients that we are getting. Granted, it will be much better if we are automatically informed about patients that are positive from test and trace, because the ward can proactively contact the patients themselves, which means that, yes, you know, those phone calls are staggered and the patients don't feel that they're trying to ring and not able to get, you know, not able to have their call answered when at the time that they make that contact, which will all help. As time progresses and as the evaluation is received from NHS England, which we're actually expecting next week, and we will need to look and work with NHS England whether we need to change and narrow our referral criteria to make sure that we are able to focus on those patients that actually we know we get the greatest benefit from monitoring. And there is going to be a potential change over time, at which point we realise that when the numbers are rising, you do have to narrow your criteria to monitor those patients that you know you get the greatest benefit from monitoring. Now, forgive me, that is not to deny this opportunity for reassurance to other patients, but unfortunately, with the novel virus, with the impact it has on other elements of the workforce, we have to be ready to flex to make sure that we focus it to those patients that we know will get the greatest benefit.
Yes, I thought there must be a notional limit or a different way of working.
Yeah, and it will be actually looking at the incidence and the number of cases and the need to change the referral criteria, and part of that will reflect guidance from NHS England as well following the result of the evaluation.
Thank you, I understand now, thank you.
Thank you. Any other questions? I don't see any. Would you want to carry on, or is it Tracy to be next?
I mean, Chair, thank you very much for giving us the opportunity to tell you about the virtual ward. Obviously, it's something that, you know, we will make sure that we share evaluation with partners so that, you know, everyone is aware of the impact of the ward, and hopefully it is a real positive for the Tees Valley, because it's really important that all of the Tees Valley is served by this enhanced remote monitoring. That's, you know, it's a good thing for the North East. We were the only pilot in the north of the country at all, so it was a really positive thing.
I think it's a wonderful thing that it's doing, because if we can be a pioneer in anything, it's one thing to be a pioneer in this, and I think if we can get it right and then spread it around the country, that'll be excellent. Thank you.
Thank you.
Tracy, do you have anything to add to that at all? No. Wonderful. Right. Thank you very much for that. We do appreciate what you've told us. Right. The next bit.
Sorry, Chair. I don't know whether Dr. Janet Walker and Tracy Innes are happy, wish to leave now.
Yeah, if you wish to leave, that's thank you. I'm sure you're very busy, and we do appreciate your time. Thank you very much for attending. Thank you. The next bit is the NHS Foundation Trust account for 2019-2020, a very large document. Have we all read it?
So we have a presentation, Chair, to complete the report. Caroline, are you able to upload that?
Yes, thanks. Thank you. Yeah, sorry, Sue. Have you got that there for us at the moment? Yeah, sorry, Sue's sharing it on her window just so that I don't lose sight of everything else, if that's okay.
Thank you.
Yeah, thanks, Mark.
Good afternoon, councillors. My name is Deirdre Fowler. I'm the Interim Director of Nursing Midwifery here in South Tees. If you could just go on a slide, please. I'm just going to give you some context. The timeline in front of you just gives you some of the key dates in our quality journey over the last 12 months. So you'll see we submitted our quality account at the beginning of last year. This was then followed in July 19 by publication of the CQC report. And in September 19, we appraised you of our progress in regards to our improvements against the report. In September, we sent you a report, and then you may recall in November, some of the members of the team came to a scrutiny panel to talk you through our progress and highlight some of the material significant improvements we've made against the must-dos in the CQC report. And then, of course, you'll see here that that pivotal moment in January 2020 when we saw a declaration of a national incident regarding COVID-19, as we've just spoken about. So through the latter half of the, thank you, just on another one. Thank you. Just in the latter half of last year, the Trust saw a change of approach to recovery and improvement to encompass operational performance improvements. It incorporated again the progress against the CQC report and indeed more recently recovery against the pandemic, the COVID-19 situation. So our approach to recovery fundamentally was to become far more clinically led and ensure that we developed a new way of deciding how resources and care was delivered and allocated throughout the Trust. This was clinically led, as I said, by the whole multidisciplinary team comprising of senior nurses and allied health practitioners, our union representatives, senior medical staff, clinical directors, and of course some medical directors in the Trust. And this approach was fundamentally tried and tested throughout our COVID journey, ensuring that clinical judgment and decision making underpinned everything throughout.
So if we go to the next slide, I'm Adrian Clements, I'm the Medical Director. I'm going to go through a little bit about a rehash of our response to COVID because it tells a bit of a story, and I'll bring you up to the present date through recovery into also the current day on our COVID preparations as we speak. So on this slide, it talks about, and as Deirdre said, our response was clinically led. Our number one priority was to protect our staff, because without staff you can't treat patients. Our second priority was protecting our patients. And then we were going to deliver as much clinical care as we could safely to the population, and that's high-level clinical care that's delivered on the James Cook site, which is a lot of tertiary care and major trauma care. To do this, we split the James Cook site into two, right from the front door to the discharge. So we split from assessment through the emergency department, and the main response on this site for COVID-positive patients was in our tower block. We separated the rest of the site that was non-COVID to keep those patients safe, and we minimised the mixing of all our staff across those two areas, and we absolutely were rigid around patient movements between those areas as well. We did the same at our Friarage site, and we looked at our Redcar and Broughton and our community teams throughout that. So we had a very robust response to COVID. If we go to the next slide. Testing was key to this. We've talked in the press about testing and how important it is. At the start of the pandemic, we couldn't test for COVID-19 on site. We had no capability. We built the capability very quickly by getting the right equipment in, rehiring some staff, a retired virologist, and very quickly we managed to get up to 30 tests a day that we focused obviously initially on some members of the community, and then we switched that as directed in this through this pandemic to patients. We grew that capability to 240 tests per day, and now we're up to 1,500 tests a day, and we can do those tests 24 hours a day. Through that capability, we've supported our neighbours in Darlington and North Tees through their testing of patients. That team has been instrumental in our response. As we all know, without testing, you can't safely cohort patients. If we move to the next slide. So throughout the pandemic, we prided ourselves on meeting or exceeding national guidance. So obviously the incident was declared as a level 4 incident, command and control, back on the 30th of January, where we take instruction centrally. The Trust started testing for COVID as soon as we built the capability back on the 12th of March. Nationally, it was dictated that on the 19th of March to push that through our discharge processes. As a Trust, we expanded that to all patients coming into our hospital for inpatient stays, however they accessed on the 6th of April. That was before national guidance came out for us to do that. And that puts us well placed for the 16th of April, when care home discharges had to be compliant with COVID testing. But as nearly 10 days before that, we tested all inpatients through any access route. We were virtually already compliant before that guidance came out. And moving through to the 21st of August, the process is on discharge to assess. We've audited ourselves robustly on this, and we are compliant with all those steps on admission, testing at 5 days, and discharge before movement to care homes. If we move to the next slide. It's been really important to us to protect our staff through this episode, and this is actually getting them up to, we released PPE protection to them earlier than national guidance across all our care areas, and we've been very key on testing. The most important thing about PPE is using it properly, knowing how to take it, put it on, and knowing how to take it off. And we've instigated things like PPE marshals to make sure that happens, because it's very easy to contaminate yourself on removal of your PPE. Once we built our testing capability on the right of this slide, we started testing our staff on site, and we had a very robust mechanism to test our staff before we let them back into the healthcare environment. And again, our standards are slightly higher than NHS England standards on this. You have to actually have a negative swab test before removal, before you can return to the healthcare environment, and we've kept that through the pandemic. If we move to the next slide. These are the list of some of the things that we're proud of. Through our strategic and tactical groups, we embedded staff side and BMA into those groups to keep all our staff aware of what we were having and how decisions were being made. We were the first Trust in the North East to have a staff policy in relation to COVID-19. At-risk staff were redeployed, and we kept in contact with them through our HR teams for those who were shielded. As we mentioned before, we released PPE to all our health teams as soon as we felt that was reasonable and prevalence in the community was rising, and that really helped our staff gain confidence on our delivery. We've partnered with the armed forces, both in training. We had to train 10,000 staff in the use of PPE, and multiple members of those teams into the use of FFP3 respirator masks. That was a significant undertaking. The military brought this idea of PPE marshals, which is absolutely fantastic in ensuring compliance with the use of PPE and also this donning and doffing. Very importantly, we had embedded psychological support at the front line in our critical care and high impact areas. This was instrumental in our low sickness rates that have come out of COVID and the psychological aspects. I'm not denying there are ongoing psychological sequelae of COVID, but our staff sickness rates are lower than comparable trusts, and I think that psychological support embedded at the front line, working alongside our clinicians, has been really instrumental in that. We were very proud of instrumenting BAME colleagues' risk assessments before issued again nationally to do that. We had 100% compliance very quickly, and we've shared those risk assessments with every single member of staff across the Trust. If we move to the next slide. So supporting our patients. At the peak of the pandemic, we had 26 COVID positive patients on critical care with 50 total admissions, and our maximum capacity normally is 32. So obviously our critical care footprint expanded into the rest of the hospital, and at the peak of the pandemic, we had 150 positive COVID patients. Now that was, I would describe as the waters lapping around our ankles, because we were ready for a much bigger wave than that, and we probably could have coped up to 350 COVID positive patients on site. But we were grateful that we were very well prepared. On the right, there's the kindness calls, because certain members of our population couldn't access services through this time, and we supported them through kindness calls to make sure they felt and understood what was happening to them and when their care could be completed. If we move to the next slide. The community were absolutely fantastic supporting the hospital. They supported us with iPads, so patients who couldn't communicate with relatives because of the visiting policy, and wellbeing packs for staff. And actually, we felt so supported by our community that kept the staff going through this COVID pandemic and out into recovery. If we move to the next slide, and the next one. So after the COVID surge, at one point we filled our tower block, which has got 12 wards in it with COVID patients. And we had to have a very clear way of de-escalating that tower block into recovery. And we did that in a staged manner, taking our staff with us, because as the COVID surge ended, we had a non-COVID surge of activity started to come back through the hospital. So we had to prepare for that activity, both elective and non-elective emergency activity. And on the bottom right is where we got to up until a couple of weeks ago with just one COVID positive ward. And up to about 2 weeks ago, we only had probably one or two COVID positive patients on site. And as we've been hearing earlier, that situation has definitely changed, which I'll update you in a minute. So through recovery, which was after the COVID surge, next slide. Next slide. The pillars of recovery again are around staff safety, patient safety, sufficient using our resources carefully, and clinical prioritisation. And what I can report, all our services have restarted fully or partially. And all those services, as they've restarted, went through a very robust quality and quality impact assessments. Now, that was the position up to a couple of days ago, and we're still concentrating on recovery, but now we're moving to thinking about preparing for a further COVID surge. If we move to the next slide. So it's critically important that our resourcing teams on site kept us fully stocked with, if we could go back one slide, sorry. So our resourcing teams kept this hospital fully stocked through PPE throughout the pandemic. They were pretty ingenious about how they did that, but we never ran out of PPE on site. And that was a real confidence booster to the staff working here. Social distancing is important. And we've learned through the pandemic that actually social distancing and PPE usage doesn't need to just take place when you're in contact with patients, but also in rest areas, because we did have some transmission between staff in our rest facilities, but we've tightened up on that. If we move to the next slide. Through our resourcing success, we've managed to distribute 600,000 pieces of PPE to other care providers and facilities. We supported other providers with 5,200 COVID tests. And we helped our care homes with supporting training and advice and guidance. We also provided online education and support. If we move to the next slide. At the end of the pandemic, the CQC came to us and inspected our delivery through COVID, and actually were impressed with the clinical way that it was delivered, how we kept our staff with us. And in their assessment, our control measures and our infection prevention control measures were very good. We had very limited or lower than other providers nosocomial infection spread on site, which is the transmission of COVID through your hospital stay. Our rates are very low against peers. Now, we heard earlier in the call about outbreaks. Now, if we address outbreaks, in the near past, we haven't had some outbreaks, but the definition of an outbreak is very broad. You only have to have 2 patients or 2 members of staff who become COVID positive within a 14-day period. And as COVID prevalence is now high in the community, it is also, some of our staff will get COVID, not necessarily in their hospital environment, but they'll bring it into the hospital from outside. So I still think that our control measures around COVID are very tight in the hospital. But the truth is, COVID is coming back in the hospital. We've gone from a period where we were having 1 to 2 patients on site with COVID. Last week it was 7 to 8. Today I can report we have 25 COVID positive patients on site. Our critical care area has now 5 COVID positive admissions, and we've had to go back into the first phase of our COVID response by segregating one of our critical care areas for purely COVID patients. We're also in the process of thinking about separating our site again, and making preparations for a separate COVID assessment unit on site for people coming into the hospital. And we'll go back up our escalator if required. So there's an awful lot of work going on site at the moment, preparing for this COVID surge. Initially, it was increased COVID numbers in the community, but certainly we are seeing those numbers starting to arrive in hospital. We're absolutely confident that we will be able to deliver a really robust COVID response again. It will have the added complexity of also having to deliver care to the rest of our population without COVID disease. That didn't happen last time. But I think that the trust is on it, and we are very confident that we can deal with this second COVID surge if and when it arrives. I'll hand over now to Ian.
Thanks, Adrian. Hello, everybody. I'm Ian Bennett. I'm the Head of Patient Safety and Quality within the Trust. I'm going to just talk to you in the next couple of slides around our quality priorities that we've set for 2020 and 2021. They're broken down into three key areas of safety, clinical effectiveness, and patient experience. So looking at the safety quality priorities first, looking at our incident reporting and how we can continue to increase the number of incidents that we're reporting within the Trust. This was a quality priority for last year, and we've seen a real significant sustained improvement in the numbers of incidents that are being reported across the Trust. And it's good that we're carrying that one forward, which is one of the indicators looking at a culture of learning and safety within the organisation. The second one is around scrutinising, so looking at where we've got areas that we want to really focus on in terms of our learning and our safety culture. So looking at where we have a never event within the organisation, and looking at some of our surgical practice within the organisations, and that we're following national policies and procedures in terms of LOCSIPs, which are local safety standards for invasive procedures, and that we're adhering to those within the organisation. And the third one is around learning and making sure that we improve the quality of our incident investigations at all level, whether there's no harm or not that occurs to the patients, and that we can share the learning with that quickly amongst the staff within the organisation. The next column looks at clinical effectiveness, and the quality priorities we set around this area are that we have a quality and patient safety strategy within the organisation, which means that we can embed that quality and safety approach and the improvement methodology within the organisation right from the frontline services, if you're a staff nurse on a ward, right up to members of the Trust board. And that's already started in development. The second one is around accreditation, and the organisation has its own accreditation system known as STAC, which stands for the South Tees Accreditation Quality Control. We had this in the organisation previously. We've done a revamp of that, and it really means that our frontline staff can get involved in assessing the quality of their own areas, and we can share the learning that comes out of that, and really embed that quality and safety throughout the organisation as well there. The third one is around discharging and making sure that our patients have a safe and effective discharge, looking at our Home First, Trusted Assessor, and our Discharge to Assess model. And then the last column looks at patient experience, so looking at how we collect that information from our patients. Last year, we went over onto the Meridian electronic system for collecting patient feedback. That's had a real success within the organisation in terms of using text message as well as technology, and allowing people to give verbal or paper feedback. We now want to embed and develop that further so that we can try to reach some of those difficult to reach groups of patients as well, and get feedback from those about our services. The second one under patient experience is around responding, so making sure that our complaints and PALS systems are robust and in line with the guidance nationally around the timescales for reporting, and also that we can really engage with our patients when they feel there's a need to complain, that we can deal with that compassionately and effectively. And the last one is around improving patient experience, particularly within the outpatients department, and continuing the work that we started to do last year as that quality priority in terms of looking at what it's like to come and attend outpatients within the organisation. Next slide, please. So I mentioned staff as one of our quality priorities for this year, and I just wanted to really share this in terms of the approach. So it consists of 4 components, looking at the culture and compassionate care within the organisation, that it's well-led care, that we avoid harm, and that it's definitely effective for our patients. And they are the 4 principles of what our staff accreditation system is about. Next slide, please.
So just back to me for this final slide. I think it's really important that we recognise that through the COVID surge that we experienced through March, April, May, this hospital just didn't deal with COVID. We did 3,400 complex operations through that time. Our theatre plans were still delivering care to vascular cases, heart cases, neurosurgical cases, and cancer cases. This lady in particular is a lady who unfortunately had a thoracic tumour during COVID. She came through our services in a very safe manner with pre-arrival isolation and swabbing. She had a thoracic cancer removed, and there you can see her on the right, back with her partner at the end of that journey. And we prided ourselves on our robustness of our processes for these high-level patients coming through our services at the height of the pandemic. And we learned a lot through our delivery last time, and that will put us in good place if the COVID surge returns to this site. I think that's the end of the presentation.
So hopefully that's given you a pretty whistle-stop but comprehensive tour of our recovery and improvement journey over the last year, and giving you some of the headlines included in our quality account going forward. So I'm sure myself and my colleagues are happy to take any questions.
Yes, thank you. Thank you for that very comprehensive report. I mean, you did cover a lot with the COVID, and there's other items which will come on in a minute. But you now feel, with the learning curve you've had, that if and when this COVID peak happens, and we're all praying that it doesn't, but I think it's going to, that you now have everything in place. You had all the things where you took the northern part of the hospital and you turned it into a COVID area. You've got all those plans in place. You've told us all of that, and you're happy with the PPE. You're happy with everything else. You said you could take 350. Could you take more than that, or is that your top limit?
So we could take possibly more, but it would. We're modelling now that we have new modelling that would dictate what the potential worst case scenario would be, and we're comfortable if the potential worst case scenario we would still manage. We have good oxygen supply to our ward areas on this site. We're fortunate in that it's relatively new estate, and we have robust plans in place to deliver care to up to 350 COVID positive patients. And as I mentioned, that last time we got up to 150 COVID positive patients. Now, the added complexity this time might be that patients without COVID might still continue to arrive in significant numbers, and that didn't happen last time. There was a significant fall off of other activity. What we will need to do this time, if it happens again, and the modelling would dictate that the pandemic might last longer and be at a higher level. So it'll have to be much more of a sustained response, and also we need to continue to deliver care to those patients who didn't have their care delivered last time through the pandemic. We did deliver care to high-level patients in cancer, cardiac and neurosurgical care, but many people's routine procedures did not take place through COVID, and that has built up a backlog. What we're also hoping to do this time, if we can, is continue some delivery of that type of care to reduce the growth of the waiting lists. We'll wait and see how bad the pandemic is and what the numbers look like. But obviously, we are now preparing for the potential worst case scenario, because I think that's a duty for us to do that.
I mean, it's really important that we ask our local community to support us again. We really need them to dig deep and protect themselves, follow the rules. So we need to work as a system and a whole community to protect our staff, to protect the public, and for people to take responsibility and protect themselves as well.
My feeling and my sense well, this time it probably will be worse, and I'm not saying that to cause any distress, but I do think we need to prepare for that. The last one was a bit of a test bed for the hospital. We put huge processes in place. We've got an awful lot of learning. We are actually ready for a next wave of COVID, and I think unfortunately that wave is coming. All the indicators to us are that the hospital impact will start from here. And if something doesn't change, that impact will significantly increase over the coming weeks. But we're absolutely confident with our ability to deliver a response to that, both in our critical care footprint and our general medical footprint. And we're absolutely confident that we can continue to deliver high-level care to patients who need to access tertiary services on this site, including our ability to respond to major trauma, cancer, vascular or neurosurgical emergencies. But as Deirdre said, the system and the local population need to help us with that. We are seeing a rise in numbers in the community. We are seeing a rise of people with COVID entering our services. And the rules of social distancing, wearing of face masks and being sensible absolutely is where the local population can help us.
Yeah, I think we understand that, and I totally agree. I echo what you say. Have you got a plan for the minor things? I mean, minor, I mean some of the annual checkups and other bits and pieces that you could perhaps take it out of James Cook and put it somewhere else. And I can speak with personal experience from that because I'm due to go in shortly. You know, are you looking at that? Because otherwise it'll just stir up a problem for the future. And I think you really need to look at that and address it.
So we are. So as I mentioned last time with the COVID pandemic, most services stopped. And we're absolutely conscious that we can't let that happen again. So we need a very robust response to COVID. We need to keep our high-level activity going for those patients with cancer and vascular emergencies. But what we also need to do is provide care to other patients with less serious conditions. Now, we still have access to the use of the independent sector, which we will use. We have access to our other sites, which we can use, including the Friarage Hospital, which we can do quite a significant amount of elective activity there, and our primary care hospitals in Redcar and Broughton. So we will think differently than last time, and it will be more challenging, but what we are conscious of is what we can't allow to happen is other patients who don't have COVID suffer as a result of excessive delays in the delivery of their care. So that's even more challenging to us this time, and it will stretch our resources further, but we are prepared for that.
Because it's said today on the news that they're looking 6 months ahead. I mean, if we had 6 months of this, it's a lot longer than the last one. You'll have to have things in place, otherwise people, well, the general health of the area will suffer, which is something we want to avoid at all costs. Could I just mention one other thing before I throw it open there? One thing that did worry me within the general report on page 21, never events. I think it was 4 previous year, there was 8 this year. I mean, can you describe a typical never event and what confidence do we have? We won't have 12 next year. I mean, I hope you're on top of these.
So a never event is an event that's been constituted, as it says, that should never happen. It doesn't mean that actual harm has happened to the patient, but these never events are constituted as never events because of the potential for harm. So historically, I think perhaps, you know, we historically had focused a lot on operational issues and performance. And perhaps our learning is that a clinically led organisation is the most significant way to reduce these incidents. Now, you'll remember that I spoke at the beginning of the slide deck that we now have a far more clinically led approach, whereby our clinicians from all disciplines are actually leading changes. And we have safety as the core and the golden thread that runs through everything we do. We are disappointed that we've had some never events this year. However, what is important is we have a very positive, and we're beginning to see a very positive and open culture of learning in the organisation. Now, this is categorised by a very positive reporting culture. So you'll see that since April, we've reported more serious incidents as well as never events. And that's because we have changed our approach, and we're now reporting near misses, potential incidents which have potential learning at the core of their, the core of what is important to us, rather than waiting for harm to occur. So it's absolutely, the never events and the serious incidents are on the Trust Board radar. It's something we discuss monthly. But we have a safety improvement plan, which is widely circulated and led by our clinicians at the point of care. But culture change will take some time. We have 5 key themes that we need to address address these never events, and culture and the emphasis on human factors and behaviour change is the area where we will give most emphasis. It's really important with never events that our staff trust that when mistakes are made, that they can report. So we don't want to take, we want to maintain a just culture. And as I said, whilst it's absolutely firmly on our radar and we own our accountability to address, it will take some time before we see these drop off.
Yeah, I see you've had the Airedale NHS Trust have a look at this, and I gather for the report is available in a few weeks. Do you hope that they given any recommendations up to now? Or are you just waiting for their report?
So, yeah, their report has been delayed as a result of them dealing with COVID again. They did give us verbal feedback at the time, and I think what I would say is the visit from Airedale was as much in the spirit of support and learning. So they learned as much from us as we did from them in terms of some of the challenges that we were facing here in the organisation. They were facing similar ones within their organisation.
So I think one of the things that we really need to emphasise is the safety culture change that happened through COVID in the organisation. So for the first time, and I've worked in this trust as a consultant for 20 years, and COVID was an eye-opener, because absolutely at the start of COVID, we set an absolute priority to protect our staff, protect our patients as the number one priority on everything that we did. And what we've learned from that is the most important conversation. So it's not about activity, it's not about performance, it's not about targets, it's not about squeezing an extra patient onto that list to get another care episode delivered. It's actually, how do we make sure that pathway that patient is going through, entering and leaving our services, is as safe as it absolutely can be. Now that will cause some patients not to have treatment. But if it reduces any harm to patients, of any significant harm like catching COVID or any other harm of a never event, that is actually something that needs to happen. And what is now in the organisation, the first part of every conversation is what does the patient safety aspect of this change? Now that isn't what happened before. We were talking about money, we were talking about performance, we were talking about activity. So, and then safety would be sort of at the end of the conversation, but it has to be at the front of the conversation. It will take some time to translate our experiences of COVID into all our normal practices. But I think there is a general acceptance that everyone relishes that, the clinicians relish that. And when we've moved to a clinically led delivery model, which our model actually here through COVID was very clinically led, which is unusual to other organisations that were mostly management led, or operationally led, we were very clinically led. I think we need to translate that in delivery of all our services, and the clinicians need to take charge of the quality patient experience and safety experience of the patient journey, and not be distracted by other pressures. So I think that's where we are. It will take some time for you to see the results of that. The never events that we've had in the past have centred in our theatre processes, and we're doing a lot of work about simulation training, learning from the airline industry on soft factors and situational awareness, and let every member of the team speak up. But we also need to do never events also can take place out with the theatre environment when people have procedures, patients have procedures in other parts of the organisation, and we need to spread the safety culture from theatre into every aspect where care is delivered. That is quite a big piece of work, but it's one that clinicians are already putting their hands up and volunteering to support. And so that's also part of our safety journey that we're on.
Thank you. My experience of James Cook has been pretty well excellent. Councillor Halalwi, you have a question.
Yes, thank you, Chair. Thank you. Just listening to what you said about the powerful description that you've just given about the change in attitude, mentality and approach to care, looking at safety as the priority. I was just wondering, in terms of getting all staff on board, in terms of the massive change in thinking, has that been a challenge really in terms of the HR, in terms of people's mindset, or has it been so obvious, given that what we've been through, that people have come on board quite easily?
So I can't remember the exact numbers, but pre-COVID, a survey was done from our staff, and about 43% of them felt the organisation put patient safety as its #1 priority. We did a pulse survey with them recently, and I think it was as high as 85% of our staff felt that we were now putting patient safety at the front of our thinking. Now, that wasn't just about talk, they were actually seeing that in action. The absolute rigour around our protecting them with PPE, training them with PPE, every single patient journey when we were restarting recovery, it had to be safe. And that was the absolute message that went through the teams. You will not restart your services unless they're safe. And they were some of the clinicians were a bit frustrated because they wanted to start quickly, and we're going, absolutely not unless that pathway is safe. And so there was significant control of that. And actually, even the ones who were initially resistant understood that. You know, we have a duty to protect the patients who come through our services, and it's our #1 duty. As well as delivering care, that care has to be safe care. And I think that is a message now that everyone has got across the organisation, both medicine, nursing, allied healthcare professions, but also operational managers. Yeah. You know, it's not just a culture that needs to affect the clinicians, it's a culture that needs to affect all members of the trust in any management position, that the #1 priority is patient safety.
I think, Councillor, the biggest change in approach and the change that will make this culture sustainable is the fact that our staff are the ones who are leading this. They're the ones who are instigating the culture change. So our approach is far more inclusive now and is built on engagement and empowerment of people at the front line.
Thank you. I think that's really powerful. But, you know, actually, as well as in your organisation, I think that message could be well transferred to many other organisations, whether it's business, schools, whatever, because safety now has to be at the heart of all we do, otherwise we potentially can't do anything. So I think that message and that powerful model is how to get through that message could be spread far and wide, quite frankly. And I admire you and all your staff for going on board like that and taking it to the heart of the way that you practice and the way that you are empowered, as you said, to deliver most effectively. Thank you for that. I'm really impressed by that. Thank you.
Thank you.
Okay, we have Councillor Hubbard followed by Councillor Rooney. Councillor Hubbard.
Thanks very much, Chair. I think we'd all like to thank you first of all for the tremendous amount of work that you've been doing. Really is inspiring. I know in this ward, Parkend and Beckfield Community Forum, they actually donated 3 tablet devices, just so in the early days especially, the patients could keep in touch with their loved ones. So we'd just like to say thank you. I don't know if has there ever been a discussion where the Nightingale hospitals are used first to keep our COVID patients in one area, because it must take a lot of resources trying to prevent cross-contamination. And I don't think any of the Nightingale hospitals were used, thankfully. And I'm not saying it won't happen this time, but I would have thought it might have been more beneficial to try and isolate to prevent cross-contamination. Has that ever been discussed? Thanks.
So, taking up, Nightingale hospitals are politically sensitive, and I don't want to get into the rationale behind them, but as a clinician, and what we've learned through COVID, that COVID patients who require critical care need a highly specialised critical care unit, which you're fortunate that this hospital is a highly specialist critical care unit, because COVID patients requiring critical care need very highly specialist critical care. I think at the start of the pandemic, people thought that you could put a COVID positive patient on a ventilator, that's all they need. Actually, that's not the case at all. There's some of the most complex critical care patients that exist and need highly specialist critical care, including renal support, lots of other support. So certainly the Nightingale hospitals, I don't think would be of any use in managing critical care related patients. What we believe they might be of use for is step down patients who require a prolonged period of stay in hospital. So if you have COVID and you're recovering from COVID, but you still need some hospital care, there is a possibility that you could step down to a Nightingale hospital. I think the truth was we never got to that phase last time. We could quite comfortably accommodate the number of COVID positive patients and discharge the ones we needed to back to their own place of residence or care facility. If this pandemic that's coming is more prolonged and of a higher peak, I think that's something that we will need to do to create capacity on the site to continue to treat COVID patients and the non-COVID patients. So that's time will tell, but I don't think it will help us with acutely ill COVID patients, but could help us with COVID step down.
Hey, thank you.
Councillor Rooney.
Thanks, Chair. I think you've just answered my question. I wanted to know about discharge because you referred to it in your presentation, and I would imagine that when a hospital under kind of normal circumstances, people are entering the hospital, you have a fairly good idea of how long they're going to remain in a bed. With the COVID patients, that seems to be out the window in some respects, so you can't gauge how quick the bed turnover would be. So my question was going to be, what did you learn from earlier in the year and as your procedures changed? And I think you probably almost answered that question, but if there's anything else you'd like to add, that would be good. Thank you.
So we will use other facilities. So last time our Redcar site was a COVID step down site and Broughton was a COVID free step down site. And we'll think again. And we might, as I've mentioned, if our services start to become overwhelmed and those step down facilities are overwhelmed, we would consider the Nightingale as an appropriate step down COVID facility. We will use all resources that can be mustered to help us, to enable us to keep capacity on site for people who need to enter our services. Clearly, it's a flow issue. As patients enter the services, we need to create capacity for them. I think the discharge to assess model that is now in place about discharging patients to care homes is robust. Clearly, we need to discharge patients safely. It would be foolish for this organisation to discharge patients unsafely into a care facility because it would just create more patients for us. And throughout the pandemic, I think we were pretty robust in our discharge arrangements with care homes. We knew the importance of them and we tried to support them as much as we could. We were discharging patients with PPE, 20 sets of PPE to help the care facilities before that became more robust. And also throughout the pandemic and before the regulations came into place, we were testing our patients prior to discharge to care homes. And we were having those conversations. Our care facilities are part of the hospital system, really. They're an extension of the way we deliver care. And so they're just as important to us that we support them as much as we support the patients within our services.
Thank you. I've got a question here from Councillor Philip wrote, there is a significant issues for pregnant mums going to their first scan at the hospital. They're not being able to bring a companion with them in this. Is this something that will be looked at given the rule has been relaxed from the second scan? And will guidance for maternity wards be updated or changed?
So we've been facilitating the birth partner or a partner to attend the 12-week scan, which is the first dating scan for some time now. However, we do have to look, you know, at our actions and our responses in lieu of rising rates to protect the mother, the unborn baby, our staff, and other mothers using the service. So at the moment, we're just looking at how we respond, and we will be adjusting our actions accordingly, depending. Certainly, we will take, we're very mindful of the psychological importance of that dating scan and the importance of holistic care for the family, but it has to be a balance of risk. So at the moment we do, but that may change in the next 48, 72 hours.
Okay, thank you for that. I know it's very difficult, and of course we don't know what's going to happen over the next 2, 3, 4 days, week or so as things rise up. But it's one important thing, and you know, I personally think that people's, whether it's a pregnant mum, whether it's an old age pensioner, or whether it's anybody, their feelings have to be taken into account. Maybe not absolutely 100% if it's not possible, but I really do think they've got to be taken into account. Just going back to the report, page 146, awful lot of red on that. Performance against key national priorities. I'm sure that you're aiming to get away from that, but a lot of red ink have been used on that report.
So yes, there certainly is red, and we would want to see more of that red turn to green around those performance key national priorities, and it's something that we will continue to monitor closely in terms of the operational delivery of the organisation, and some of those are not where we want to be in terms of you know, our 4-hour target. You know, some of these are set nationally, you know, around our infection control rates, etc.
I think what's important to state that some of those targets are reliant on a system response as well. So we are working really closely with primary care colleagues and in the integrated care system to address that together as a system, as opposed to just being within our gift. Although, as Ian has said, we absolutely own our accountabilities in that area. And some of our quality priorities for the year ahead will address some of those improvements needed.
Thank you. One other quick area is looked after children. Now, I know our new head of children's care, Sue, hates the word lack, but it's there anyway. But we have a lot of looked after children, very sadly, in area, and the report goes into detail about that. Says here the assessments has to be carried out in 20 working days. Are these mainly stuck to, or is there still room for improvement there? So
we maintained our health assessments throughout COVID. We worked differently. We worked through virtual, through you know, over virtual reality, etc., to undertake those assessments. It's a challenge, and it's a challenge that is very much on the system radar and on our radar. We're in conversation with commissioners at the moment about how we meet that challenge, but certainly at the moment we are keeping on top of the challenge, but we are concerned that post-COVID and on the return to school that we will see a lot more challenges be revealed. So it's something that we are very aware of and is a risk, certainly, but at the moment we're keeping on top of it. Sorry, are you on mute? Apologies, we can't hear you, Chair.
Hello, can you hear me now?
Yes, we can. Thank you.
What I was saying, on page 123-24, you've got about the number of complaints, formal complaints, appears to have gone up, and from 2018-19 to 19-20. Not in every case, but I'm sure that that's an area that you are looking at as well.
Absolutely, and you know, we whilst you know we are sympathetic and want to get to the bottom of people's complaints within the organisation, it also is an indication of you know how we can resolve that in the most efficient and effective way for them, which meets their requirements in terms of that complaint. You know, so some of those do come through as just a concern that's been raised or Carl's inquiry, and it's much better for the patients and the carers and our staff really if we can resolve as many as possible informally rather than proceeding to a formal complaint.
I think, Chair, a much better marker of success is our response times and how we respond to our complainants, and also how many complaints are reopened. So we have really good success in terms of most complainants are very satisfied with our initial letters of complaints. So I think we're trying not to emphasise numbers of complaints, bare numbers alone, as a marker of success or failure, because part of our approach is to encourage people to give feedback, and it's only through feedback that we can improve our services even more.
So one of the most important things about when people raise concerns or a question, and it can just be a question because they haven't understood part of their care journey, it's not always a complaint, but it gets labelled as a complaint, is a strand of our governance. We have to learn from those questions that have been raised. We have a very robust process at the local level to answer the complaint, but every complaint that leaves the organisation has been reviewed either by the Director of Nursing or the Medical Director before it's seen by the Chief Executive. So people, if they are posing a question about the care they had during our services, they need to be assured that actually it's been through a very thorough, robust process. And if there's anything that I highlight or Deirdre highlights in that complaint, we will go straight back to that clinical team, and we want, we want the questions to have been answered that have been asked in the complaint by the complainant, and we'll actually, and if there's anything significant where we believe the service change needs to take place, we'll do that. So it's actually learning the lessons of the query that's been raised to us, and it's not just about answering the complaint and getting the complainant to be satisfied. Is if we do need to make changes to the way that we're delivering our services, that is actually one really important strand of information that we can use.
Thank you, because I notice on figure, I think it's 25, it suddenly shoots up, and I presume that could be on feedback of asking a different question, I suppose.
Yeah. Absolutely, and you know, themes and questions, you know, we monitor those as part of our complaints process as well, and we then look at those in detail, particularly the sort of top three areas, and it does fluctuate. You know, some months the numbers are quite low, and then they shoot up again, and you know, we just do our very best to keep on top of those and respond to them as soon as possible, whether that's over the phone or face to face or in writing, whichever the complainant chooses to do is the most appropriate way for them.
But I must say, I believe that the vast majority of the population we serve, on the whole, are happy with the care that they have delivered at James Cook. Most of the letters, they might have a query, but many patients are coming through really complex care. And some of them are really detailed about the care they've had delivered through multiple different, sometimes from other providers who've been delivered eventually here. And I can understand often by reading these complaints why the patient might be concerned. And one of the things that we have is a responsibility to just explain to them what's happened, because it can be really complex. I'm not saying some of them are 100% happy with what has happened, but these are people's lives that have been affected. They've had a serious illness or something, and they're concerned, or their relative is concerned. And I think that's something that we have to take count of. But the raw numbers aren't really the importance. I think, as Deirdre said, is how quickly we respond to those issues raised, and how do we learn from them, and what learning we've taken from them.
Yeah, one quick thing that I would say there is my own personal experience of problems, and I've never really complained about it, is how many things get cancelled either on the day because the specialist has had to, or still on holiday in a couple of cases, or has had to go somewhere else. If a patient's more than 10 minutes late, you usually place in the queue, but it can happen, and it's happened to me on numerous occasions, that things have had to be called off for whatever reason. So I think that's one area that you need to look at. Yeah,
certainly take that on board. Thank you.
Thank you. Any other questions? I don't see any hands raised. No. One last thing I would say is about staff satisfaction survey. I think it's been put somewhere that some of your staff have put in various comments and things like that. I presume, again, under the new regime, you're taking that very seriously.
Yes, we certainly are taking that seriously, and you know, as Adrian mentioned in the presentation, you know, as well as doing the annual staff survey, you know, we are regularly getting feedback from our staff in terms of how it feels to work here in the organisation, you know, the support that's available for them, and we'll be able to include that in next year's quality account. You know, the feedback that's in the report was from last summer. You know, as you've heard us talk about here today, as part of this presentation, we have taken a very much a different approach, a clinically led approach, which is, you know, really about engaging the staff at the front line, listening to what they're saying, and, you know, we're really hopeful that we will see that different approach being reflected in the feedback that we get from our staff in our next survey.
Okay, thank you for that. No other questions for them? Thank you. I mean, you've answered everything extremely well. I think that as long as you're taking these into account, because it could be looked at making grim reading. It isn't, but it's just when you look at red and things like that, and we just want to make sure that you're on top of it, which you assure us we are. Thank you very much for your report.
Thank you, Chair.
Thank you.
Chair. Sorry, Chair, could I just come in there? Obviously, we're required to produce a statutory response in respect of this. So it's just to clarify, if I draft something based on what the members have talked about today and forward that to you by, say, 5 o'clock tomorrow, would that be okay with your trust?
That would be fantastic and very helpful. And we can include that in the final report when it gets signed off early next week, yes.
Okay, that's great. Thanks, Chair. So if I just draft something first thing tomorrow morning and send it round to everyone, and if anyone's got any comments and then forward it onto the trust, would that be okay with everyone?
Yep, that's fine. Thank you.
That's great. We'll arrange for that then to happen. Thank you.
Yeah, can I thank every member of the trust who attended. Thank you very much for your very candid and very detailed report. Thank you very much for attending.
Thank you.
Thank you.
Thank you.
Thank you. Bye.
Bye-bye.
Bye.
Bye. Right, the next is a regional health scrutiny update. That's what we've just talked about.
Would you like me to come in with that?
Yeah.
Sorry, Chair. It was obviously just to say that there was a meeting of the Tees Valley Joint Health Scrutiny Committee last week, and they looked at the quality accounts document for the Mental Health Tees Esconway Valleys NHS Foundation Trust, and a response was drafted to their quality account document on behalf of the 5 local authorities, because obviously the Mental Health Trust provides mental health services for all of the 5 local authorities within the Tees Valley, unlike South Tees, which only provides services predominantly to the South Tees area. Therefore, there's a response drafted, and if you're happy, I'll send that round to all members of the panel so that you've seen that response that was provided.
Yes, thanks, Caroline, for that.
Sorry, I think Alma wants to come in, Chair.
Sorry, Alma, go on.
Yeah, I was just going to say I attended that meeting, and it was a really interesting thing across all of the Valley. Brian with their 2 words and Karen, and I'd like to thank them for producing that synopsis, which is a very clear account the report about the research when we were presented with it on Friday. So thank you to Alison, and thanks. It was a real set of responses and reflections. I appreciate that.
Good, thank you. Next, Overview and Scrutiny Board update. At the last meeting, the chair of the Overview and Scrutiny Board very kindly let all the chairs off from giving any reports because haven't met very much. But like with a lot of these meetings, a lot of these, the Overview and Scrutiny Board has been concentrating on COVID and the council's general response to it. I think there's been some interesting conversations held, I think, on OSB, and of course we're due to have another one as well. I think basically at these meetings we've had the mayor, we've had of course Mark Adams, etc., and I think most people on this committee who actually attended those meetings. I don't know whether anybody else has any other comments to make on that, but it was mainly to look at COVID and look at the council's response. And I think we should be proud of what the council's done. I say earlier on with the face masks going round and the letters that have gone round. I think it's been an excellent response, and we can be held up as a shining light to other councils. Councillor Halawi.
Thank you. I think the last OSB was really interesting and very useful. I think it was good to know that we've got the work programmes up and running for all the different scrutiny panels. Yep. And I think that there's going to be some really interesting discussion and debate and information sharing. I think that the focus on the last OSB was on education, and we got some interesting reports back on aspects of education in the town. And of course, as you said, the way that COVID's affected the delivery of the education programmes. And next time it's going to be on finances, isn't it? So that will be really interesting on the 1st of October to get the feedback from the exec member on the financial situation, because the COVID impact there will be really interesting to find out more about as well. So I think the meetings are really excellent and very important and make a huge contribution to the sharing of knowledge amongst councillors and amongst everyone in the office and all the staff that work for the council. So I think these meetings are even more important now than ever, because they're a key vehicle for sharing information and having an opportunity to discuss and ask questions. Thank you.
Yeah, absolutely. I think that the attendance of these meetings are very good as well, perhaps better than when we met in the town hall. So I would thoroughly agree with that. I think we're the ones for COVID, the education was, I know that's your area of expertise, or you're one of your many areas of expertise. So yes, education was certainly a hot topic and should be so.
David, I think Brian would like to come in.
Sorry, Brian. Yes, sorry, I didn't see it. Brian.
Yeah, I know that we've noted that all the meetings are up and running now. And I think we should put on record our thanks to all the officers who've helped in this. It's been no mean feat. Worked tremendously hard. As Sue stepped in today, and I think though, as a team, I don't think we could get any better in the northeast. Probably the amount of work that they do. I just take my hat off to them. If I had a hat on, I'd take one off. So just say thanks very much, and I'd just like it to be noted that it's in the records.
Yeah, I think we all agree with that. It's never too much trouble. We find with the officers, we can contact them, we can ring them, we can email them. Never too much trouble. They probably think, "Oh God, he's ringing again," but they never say that. They always pull out the stops as they have done for this meeting. So we're so lucky in Middlesbrough that we have such an excellent democratic services. So there we go.
That's right.
Take a pat on the back from all of us. Thank you. So I think, oh yes, well we've mentioned the OSB. So does any other matters? I'm not aware of any other matters. So
sorry, Chair. Sorry, Chair. Yeah, could I just come in? It was just that the minutes from the meeting from the 10th of March hadn't been approved.
Oh yes. I know I printed it off. Yeah, I have them here. Yes, sorry about that. Yes, the minutes for the 10th of March, the scrutiny panel, were not approved. I'm sure most of us were there. Yeah. Okay. We're happy with those. All approved. There we are. All done. Simple.
That's great. Then we can publish them on the website.
Yeah, we can publish them on the website. Yeah. Okay. So if there's nothing else, I thank you all for your attendance. I think it's been an excellent meeting today. I think we're just on the verge of, let us hope not, but some more COVID. It does sound like we are really prepared for it, and with the excellent help of the health service, we will get through this. Thank you for all attending. Thank you.